Hello, nurses. This is Mrs. Ignacio. We're going to be talking about the cardiovascular system today, the gastrointestinal system, and musculoskeletal systems. So I'm going to focus on the diagnostic tests and the alterations, but remember, for every body system, you always want to look at the anatomy and the physiology, how to assess it. Remember, we're always using ADPI. You're also going to think about what's normal versus abnormal, the nursing considerations, and that's going to include patient teaching as well as the medications. So let's talk about the cardiovascular diagnostic tests. Well, lab tests for your cardiovascular patient is going to be serum electrolytes, your erythrocyte sedimentation rate, that is your ESR. Remember, elevated ESR indicates inflammation in your patient. We're also going to be looking at C-reactive protein, looking at blood coagulation test, that is your PTT, and that's most significant if your patient has heparin therapy. The PT is most significant if your patient is on warfarin. We're also going to be taking a look at the INR, the BUN, and creatinine, and that is going to be reflective of kidney function, the BUN and the creatinine, okay? We're also going to be looking at this cardiovascular patient's serum cholesterol levels. Remember, LDL is the bad cholesterol, and HDL is the good cholesterol. We're also going to look at the BNP, B-type natriuretic peptide. And so this is an indicator for diagnosing heart failure. There is going to be a critical value of BNP if it's greater than 100. So what is the gold standard for determining if the patient had an MI? Well, that gold standard is troponin, 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 troponin. All right, let's talk about EKG. So EKG is measuring the electrical activity of the heart, and we usually will perform a 12-lead EKG within 10 minutes of onset of chest pain. Now, obviously, if the patient comes to the emergency room, as soon as they get there, we will conduct or we will perform an EKG. That patient will remain on heart monitoring. So remember that the P wave represents the atria contracting, both left and right atria, and the QRS complex represents the ventricles contracting, and the T wave represents the ventricles relaxing. Ventricles relaxing mean that they're filling up with blood. Okay, so that's important to note what the PQRST complex means. All right, let's talk about cardiac catheterization. Cardiac catheterization is a procedure where a catheter will be placed inside of the patient. They usually make an approach through the femoral artery, and this will get them to the coronary arteries. So they're going in through the groin, through the femoral artery. They may use dye to visualize any blockages, and then the patient can be treated, if there are blockages, with percutaneous coronary intervention. Okay, so what is that exactly? Well, there can be coronary angioplasty or a coronary stent. With coronary angioplasty, if there is a blockage in that coronary artery, remember coronary arteries are the arteries of the heart. If there's a blockage, they can perform coronary angioplasty, and a balloon tip catheter will be used to press that blockage to the side, and they will open up that coronary artery. Remember, coronary arteries serve the heart and help the heart itself to get oxygenated and nutrient-rich blood. Coronary stent is also the second type of PCI, and remember, PCI is percutaneous coronary intervention. And a stent will be placed in. And what is a stent? It is a piece of metal mesh that stays in place, and it prevents that blockage from reoccurring in your patient's coronary arteries. So this is a pretty serious procedure that the patient will have done, and always think about when there's an invasive procedure, I'm afraid of hemorrhage, infection. I always pre-procedure have to make sure that the signed informed consent is placed in the patient's record. I will know that I have to get blood work done for the patient. I know that I have to prepare the area, especially if it's in the groin. I might have to shave that area, clean it properly. The patient will be NPO for 6 hours prior to. I want to mark the distal pulses for this patient that is going to have this PCI done. Again, that is percutaneous coronary intervention. You may think of it as cardiac cath. It's the same thing if the patient's going to the cath lab. We have to do all of these things. Explain to the patient that the procedure may leave a metallic taste in their mouth. Of course, we're going to assess for dyes, allergy or allergies to shellfish and iodine. And we're going to make sure that we get those distal pulses marked and get some baseline vital signs. Now, after the catheterization, we're going to monitor the patient's blood pressure, their apical pulse, every 15 minutes for 2 to 4 hours, because we want to make sure that the patient's condition has stabilized. We're going to monitor for any bleeding, assess them for chest pain, and we'll make sure that we tell the patient to flush their system with fluids so they can get rid of the dye. And they will keep that extremity extended for 4 to 6 hours. So if they went and made a right side approach on the right side of the groin, the right femoral artery, this patient's not going to be up out of bed. They need to stay in bed, lying in a supine position with that right leg extended to promote blood flow back to the heart, okay? All right, so no hip flexion, no sitting up, okay? And I'm sorry, they're not going to keep that elevated. They're going to keep it extended, rather. So not elevated, extended. Okay, all right. So transesophageal echocardiogram. This is an echocardiogram that they're going to go through the mouth, and that is the picture that you see here. Whenever we're going and making approach through the patient's mouth, I'm always concerned about airway. This patient pre-procedure will be NPO for 6 to 8 hours. We'll clarify any medications that need to be administered prior to. And post-procedure, the big thing is gag reflex. Gag reflex. I'm going to monitor this patient's airway. That's going to be a huge thing that we are concerned about. Okay, let's talk about now these alterations in the cardiovascular system. Angina. Angina is a manifestation of myocardial ischemia. Whenever there is ischemia, there is a blockage to a blood vessel, and that means that those cells and tissues distant to this blockage are not getting oxygen and nutrient-rich blood. What happens to our cells and tissues when they don't have oxygen? They die. So this is pretty significant. So this patient that has angina, they may have an arterial stenosis, which is a narrowing or a blockage. They may have uncontrolled blood pressure or cardiomyopathy. So when we have this patient, we may be wondering, well, what are some of the contributing factors? Well, family history, advanced age, hyperlipidemia, tobacco use, hypertension, diabetes mellitus, obesity, and physical inactivity. So sedentary lifestyle is not going to benefit your patient. So how does this angina manifest itself? Through chest pain or discomfort, pain in the arms, back, neck, jaw, shoulder. The patient may also complain of nausea, fatigue, shortness of breath, anxiety, diaphoresis, which is sweating, dizziness. The diagnostic procedures for angina: 12-lead EKG, cardiac stress test. Remember, cardiac stress test is a test where they're going to wear loose, comfortable clothing and their running shoes, because they will be getting on the treadmill, start out walking, and then they will increase to the point where the patient is jogging or running. Now, of course, if the patient is physically unable to get on the treadmill, then they can chemically induce this stress test. But of course, it's preferred for the patient to walk or jog or run, whatever their capability is. Another diagnostic procedure when we think of angina is echocardiogram, cardiac enzymes, and biomarkers. And so those diagnostic procedures are going to be pretty much the same for all of our cardiovascular issues. So just keep those in mind. So what is the nurse's role in caring for this patient with angina? Well, we're going to assess the pain, and that's going to be using the PQRST of pain, the location of the pain, the character, the duration, how long it lasts. What are the precipitating factors? What was the patient doing beforehand, before this pain came on? We may administer oxygen as needed. Medications that may be given: aspirin, nitrates, such as your nitroglycerin, beta blockers, statins, calcium channel blockers, and even your ACE. So that's your angiotensin converting enzyme medications. We will do some patient teaching. We want this patient to avoid constipation, because if they're constipated, that is going to cause more stress on their heart. We want them to avoid excessive activity in cold weather, decrease their stress, get some exercise, have a low sodium, low fat diet, maintain a healthy weight. They should rest after meals, and we will promote tobacco cessation. Let's talk a little bit about nitroglycerin. That's one of the very important medications when we talk about the cardiovascular system. So this medication, nitroglycerin, should be taken as needed at the onset of chest pain or tightness in the chest, or if they're getting ready to exert themselves, meaning they're getting ready to go exercise, or they're getting ready to go mow the lawn. So take the nitroglycerin as prescribed at the onset of attack, and every 5 minutes up to 3 doses. If pain is not relieved after the first sublingual tablet, call 911. Sublingual means under the tongue. Store nitroglycerin in a dark, dry spot and replace every 6 months. And side effect of taking nitroglycerin can include headache and hypotension. So nitroglycerin can come in tablets, ointments, patches, or sprays. If the client is given nitroglycerin for prevention, they must understand that they should be nitroglycerin free for 12 hours. So what does this look like? 12 hours in a 24-hour day. So what does this look like? If the patient has a transdermal nitroglycerin patch, they will wear the patch for 10 to 12 hours during the day, and at night before they go to bed, they will remove that patch. If we are removing the patch, nurses, we will wear gloves. We will, if it's in a home setting, we will close that patch, or the patient will close that patch with the medication side inside, and then put it into a closed trash receptacle so small children and animals cannot get to it. That's really important. Okay, if the patient has this patch, again, we will apply it in the morning and remove it at bedtime. So when the patient is taking nitroglycerin, they need to sit down and stop all activity. Okay, and if this patient is taking nitroglycerin, erectile dysfunction medications are contraindicated. That is very important. All right, let's jump right into myocardial infarction. So what is an MI? So this is when myocardial tissue is destroyed to reduce coronary blood flow and lack of oxygen. And so there's actually necrosis, death of heart muscle. Okay, and that's what's happening with an MI. So what contributes to MI? Atherosclerotic heart disease. Remember, atherosclerosis is the hardening of the arteries as it's filling with plaques because of high cholesterol. Another contributing factor can be a coronary artery embolism. Okay, so that embolism is a free floating clot, or maybe it could be plaque that is actually floating through the bloodstream. Now, how does the MI manifest? This is characteristic. This is NCLEX material all the way. Severe chest pain, unrelieved with nitroglycerin or rest. It is crushing in its quality, radiating to the jawline, the left arm, the neck, and the back. Remember, Women, older adults, and patients who have diabetes often report no pain. The patient may be diaphoretic, they may have nausea, vomiting, anxiety, fear, a feeling of apprehension and doom. Vital sign changes. They will have tachycardia, hypotension, dyspnea, and dysrhythmias. So what are we going to do? Well, the laboratory results, we're going to see troponin. Remember before we said troponin is the gold standard. So we're going to take a look at the troponin. We're going to look at the myoglobin. We're going to look at the CKMB enzymes. We're also going to have a 12-lead EKG for this patient. And this is going to be really important, this 12-lead EKG, because we're going to see if it is a STEMI or a non-STEMI MI, okay? And STEMI means ST elevation, myocardial infarction, or non-STEMI, that there is no ST elevation. Okay, so for my nursing considerations, we want to rest the myocardium, which is the middle layer of the heart, and that is the heart muscle itself, and we want to preserve what's left of the heart muscle. Okay, so we will use the acronym MONA: morphine, oxygen, nitroglycerin, and aspirin. We will monitor the vital signs, O2 sats, and again, that EKG will provide emotional support to the patient. And then we're going to later on educate them on a low salt diet, low cholesterol, low fat diet. And we will administer stool softeners because we don't want this patient to bear down or perform the Valsalva maneuver. They will use a bedside commode because that is actually less energy than the bedpan. We want to promote self-care in this patient, and we will plan for cardiac rehabilitation, which is tertiary prevention. When you see primary, secondary, and tertiary prevention, cardiac rehabilitation is tertiary prevention. This patient should initiate an exercise program, but if they are fatigued or if they have chest pain, then they should stop and contact their healthcare provider. Okay, we will encourage the use of stress management techniques in this patient. We also want to teach the patient to modify their risk factors if possible. So what's that? Obesity, stress, diet, hypertension, tobacco use, and physical activity. Now, the risk factors that they cannot modify is hereditary, age, race, and gender. This patient may also be using anticoagulant or antiplatelet therapy. So bleeding precautions will be in place. Okay, so the anticoagulants and antiplatelets include heparin, aspirin, which is usually 81 milligrams of baby aspirin, warfarin, enoxaparin, and clopidogrel. So remember all the things that go with bleeding precautions. We want this patient to not be injured, not playing contact sports, soft bristle toothbrush, electric razor, all of those things that go along with it. We're looking out for blood in their stool, blood in their urine, looking out for nosebleeds, epistaxis, hematuria, and we want to make sure that we tell the patient if they're bleeding that they need to report that immediately. Okay. All right. So let's see. So that's a little bit on MI. Let's jump into heart failure. So heart failure is the inability of the heart to meet the tissue requirements for oxygen. So this patient will have fluid overload or inadequate tissue perfusion. So there's two kinds of heart failure. Could be left-sided or right-sided. So when we think left-sided, I want you to think lungs. Dyspnea, cough, crackles, orthopnea. They must be in the upright position in order to breathe with pillows or the bedside table. Paroxysmal nocturnal dyspnea. The patient will be sleeping and then they'll feel like they're choking on their own fluids. Okay, again, left lungs, low oxygen saturated levels. And again, this is everything occurring with the left. So these are all manifestations related to pulmonary congestion. Okay, left lungs. Right-sided heart failure patient. They may have dependent edema, so their lower extremities will be edematous or swollen. They may have enlargement of the liver, enlargement of the spleen. They may have ascites, anorexia, vomiting, weakness, weight gain, JVD, which is jugular venous distension. So when we think right-sided heart failure, that is before that blood, deoxygenated blood, comes back to the heart via the right side. Okay, so this is your heart failure patient. So my nursing intervention for the heart failure patient is to auscultate the lung sounds to detect any wheezes or crackles, and those would be adventitious lung sounds. I would monitor the patient for those, and I would administer oxygen therapy as needed. This patient should never be supine. They should be in the Fowler's position to help them with their breathing. Fluid volume is going to be important. This patient is probably going to be on I's and O's, a low sodium diet, and we want to have this patient on daily weights. Daily weights are taken first thing in the morning after they empty their bladder. If there is an increase of 2 to 3 pounds in a 24-hour period, that is a cause for concern, because 1 kilogram or 2.2 pounds is the same as 1 liter of fluid. And if they gain 2 to 3 pounds in a 24-hour period, that means they are holding on to 1 liter of fluid. And we have to determine where that fluid is. Is it in their lungs? Is it in their lower extremities? So very, very important. So you could imagine that this heart failure patient is going to be on diuretics. Whenever a patient is on diuretics, I'm really concerned about their fluid electrolyte. Specifically, I'm concerned about their potassium, their sodium levels. And we know that with potassium, we have to look out for the functioning of the heart. We have to take that EKG. We have to have them on heart monitors. That's going to be really, really important. Any patient that is on diuretic therapy. Diuretics should be given in the morning, not at night, because the patient will diurese. This patient on diuretics is a fall risk as well. Now, your heart failure patient will not only possibly be on diuretics, they may be on cardiac glycoside, digoxin, they could be on ACE inhibitors, they could be on hydralazine, they may be on your nitrates, your nitroglycerin, beta blockers, calcium channel blockers. So there's a lot of different medications based on, what's going on with the patient that they could be prescribed. So we have to become familiar with all of those. Now, let's jump to valvular disorders. We know that there are 4 valves in the heart, and the opening and closing of those valves make sure that the blood goes one way. So those valves make sure that the blood goes in one direction. Now, if the valves are damaged, if they have stenosis, if they're narrowed, if they're damaged in some way, the blood flow will not just go in one way. There could be backflow of blood, and that is called regurgitation, and that is heard as a murmur. Okay, when we are listening or auscultating heart sounds, that is heard as a murmur. So remember, we have these 4 valves, and they're the mitral, aortic, tricuspid valves, okay? And so this regurgitation can affect those 3 valves, but don't forget the 4th valve is the aortic valve. So if you don't remember your cardiac landmarks, all people love Time, or all people enjoy Time Magazine or Ape to Man. That's a mnemonic for the cardiac landmarks. Make sure you go over those. Okay, so again, these valvular disorders can affect the mitral valve, the aortic valve, or the tricuspid valve. Okay, and I didn't say the pulmonic valve, I'm sorry. The pulmonic valve is the 4th valve. Okay, I think I said aortic twice before. So again, the 3 valves that may be affected by valvular disorders: mitral, aortic, and tricuspid valves. So in this patient that has valvular disorders, we want to see if they have a history of endocarditis. And whenever there's itis, there's inflammation of, and in this case, it's the inner lining of the heart. So endocarditis. Do they have a history of rheumatic fever? Okay, so How does this patient present? What are the clinical cues? Well, your patient that has right-sided heart failure, they may have mitral stenosis, mitral regurgitation, tricuspid stenosis. If it's left-sided heart failure, they could have aortic stenosis, aortic regurgitation. They will have murmurs that upon auscultation with the bell of the stethoscope will hear these murmurs, and they can also have decreased cardiac output. So the management for valvular disorders is very similar as for our previous patient that we had for heart failure. So we really want to understand those things going on. Now, your patient may actually have a valve replaced, and if the patient does have the valve replaced, they will be on prophylactic anticoagulants for 3 months, and for the rest of their lives after having valve surgery, they're going to require prophylactic antibiotics prior to any future invasive tests, and that includes dental procedures like a root canal. They must take antibiotics prior to this invasive procedure because these invasive procedures can end up introducing infection, and specifically infection to the heart. So that's really, really important because we want to prevent infective endocarditis. All right, let's jump into aortic aneurysm. So this is a local distension of the aortic artery wall, usually thoracic and or abdominal. So it is monitored until it's above 5 centimeters. And so when the rate of rupture increases, surgery is usually required. So what's the contributing factors to this? Atherosclerosis, infections, inflammatory disorders, connective tissue disorders. So the patient is frequently asymptomatic, but they may complain of thoracic pain, dyspnea, hoarseness, coughing, dysphagia. If they have abdominal aneurysm, they may have abdominal pain, persistent intermittent low back or flank pain, and they may have a pulsating abdominal mass. So the diagnostic procedures, CT scan, MRI, X-ray, and ultrasound. Remember all your nursing considerations for all of those tests. Okay, so collaborative care and the nursing intervention, well, this treatment for aortic aneurysm usually involves surgery. So we want to monitor the blood pressure, we want to monitor peripheral circulation, we want to look out for any post-operative complications like arterial occlusion, hemorrhage, infection, and renal failure. So this is a pretty serious condition if the aneurysm does rupture. All right, let's go to hypertension, the silent killer. So this is a persistent blood pressure above 140/90, often again called the silent killer. So with this, we think about primary and secondary hypertension. Okay, so secondary hypertension is due to an identifiable cause. Primary hypertension, we may not necessarily know, but it's most common amongst African Americans. Late manifestations are headache, fatigue, dyspnea, edema, nocturia, and blackouts. So for your patient with hypertension, we want to teach them weight control, tobacco cessation, decrease alcohol and caffeine intake. We want them to regularly exercise, reduce their stress, sodium restricted diet. They may have a DASH diet. And the initial medications include diuretics and beta blockers. Diuretics and beta blockers. So those loop diuretics, think furosemide. The thiazide diuretics, HCTZ. And again, whenever your patient's taking these diuretics, we're looking out and monitoring carefully their potassium levels. Now, the patient may also be prescribed potassium-sparing diuretics like spironolactone, and beta blockers may be prescribed like propranolol, atenolol, metoprolol. Remember, your beta blockers can be very dangerous and contraindicated for your patients who have asthma because they can cause bronchospasms, okay? So other medications that can be given for hypertension besides the ones we mentioned can be the ACE, the angiotensin converting enzymes, calcium channel blockers. Now, for your elderly patients, your geriatric patients, remember, we want medications to be starting at half the dose of younger clients because in our geriatric patients, everything is slowing down. And we want to avoid any toxicity, okay? We want to assess our geriatric patients for postural hypotension, which could be secondary to the medications, okay? So those are all things when we think about hypertension. All right, let's go to peripheral vascular disease. When we think vascular, we think arteries and veins, okay? So when we think about peripheral vascular disease, there's two categories. It could be peripheral arterial disease and peripheral venous disease. Okay, so this first picture talks about arterial. So when we have the arteries, remember that the blood flow in the arteries is rich in oxygen and nutrients. If the patient has peripheral arterial disease, it impairs the blood flow to the arteries that carry blood away from the heart, and most common in the arteries of the legs. That's why we have the picture of the arteries of the legs. So what goes with peripheral arterial disease? Intermittent claudication, that is pain and cramping when walking, and it resolves with rest. If the patient says, I can walk 10 feet, their claudication distance will be 10 feet. That's how far they can walk before they start having the pain and cramping. They can have calf muscle atrophy. The skin will appear shiny with hair loss and thickened toenails. They will have poor neurovascular integrity, and they will have ulcers that are necrotic. They look like they're punched out, but they don't have any edema. They can have tingling and numbness of the toes, cool extremities with poor pulses. So when we think about venous disease, think about the veins promoting blood flow back to the heart. Okay, and so when we think about peripheral venous disease, I'm afraid of venous insufficiency. I am concerned about varicose veins. I am concerned about venous thromboembolism, which can also include DVT, deep vein thrombosis. So contributing factors: prolonged sitting or standing, obesity, pregnancy, thrombophlebitis. So this patient will show, they'll have clinical cues of stasis dermatitis, a brown discoloration. They'll have edema. Stasis ulcers typically found around the ankles. So for the nursing interventions for both of these, we really want to make sure that we are positioning the legs properly. So when I say both of these, when I think of peripheral arterial disease, I will dangle the legs. When I think about peripheral venous disease, I will elevate the legs. Okay, so that's an important note there. Okay, let's talk about Buerger's disease, thromboangiitis obliterans. Thromboangiitis obliterans. This is a reoccurring inflammation of the arteries and veins of the lower and upper extremities, resulting in thrombus and occlusion. So there is a genetic predisposition. Cigarette smoking and chewing tobacco also contributes to this, and it also more oftenly occurs in men ages 20 to 35. So this patient with Buerger's disease or thromboangiitis obliterans will have intermittent pain in the legs, feet, arms, and hands, and the pain eases when activity is stopped, okay? Again, that's claudication. Now, cold sensitivity is Raynaud's phenomenon. Cold sensitivity is Raynaud's phenomenon, and that is usually in the hands. So with your patient with Buerger's disease or Raynaud's, we want to reduce stress. We want to promote a good circulation, and that includes smoking cessation. All right, so we're going to just stop talking about cardiovascular. I'm going to jump in to my next body system. Let's talk about GI for a moment. So we're going to talk about, okay, let's see. Let's go to our gastrointestinal disorders. Okay, gastrointestinal disorders. Okay, so we'll start with gastrointestinal disorders. So when you think GI, I want you to think everything from the mouth to the anus. So anything within that realm can be affected when the patient has a gastrointestinal alteration. Also remember that the liver, the pancreas, the gallbladder are accessory organs to the digestive system, so we can include them as well in alterations. Now, when we think about diagnostic procedures for these GI disorders, we think about getting our gastric aspirate. We think about our blood work, our hepatic or pancreatic enzymes, right? We're looking at albumin, ammonia, cholesterol, liver enzymes, your ALT, your AST, your pancreatic enzymes, which is your amylase and your lipase. So we want to look at all of those things. Also, we will be thinking about parasites or bacteria or bleeding. So that involves looking at the stool. There's a breath test to monitor for H. pylori. There's also the endoscopy, where we're actually visualizing the tissues with a flexible camera. There is the barium swallow. We can do an upper GI series, which is the barium swallow, or a lower GI series, which is the barium enema. We can also have a liver biopsy, and remember with a biopsy, whatever the organ that's being biopsied, a large bore needle is going in to remove fluid, cells, and tissues and sending it to pathology to be examined. Also for the GI system, we can have a paracentesis, and this is where a needle is inserted through the abdominal wall into the peritoneal cavity, withdrawing fluid due to ascites. Now, the thing with this is we don't want to remove all the fluid at once because that can send the patient into shock, because sometimes there could be as much as 4 to 6 liters of fluid. So we want to do it very slowly. So they may have a drainage tube that is connected to them. Okay, so just to mention also, there's different kinds of nutrition. When we think of enteral feeding tubes, this is delivery of nutritionally complete tube of food directly to the stomach, the duodenum, or the jejunum. So remember, enteral feeding is going, this feeding is being put directly into the stomach, the duodenum, which is the first part of the small intestine, or the jejunum, which is the second part of the small intestine. So remember, let's see. Okay, so that's good for that. Let's talk about TPN for one moment. TPN is total parenteral nutrition, and the patient with TPN has to have a central line, and the bag, the tubing, and the filter for TPN must be changed every 24 hours. We have to monitor every 6 hours this patient's blood sugar, because if the patient is on TPN, we're concerned about hyperglycemia. All right, so let's talk about trying to see what my picture is showing. I want to mention, let's talk about GERD for a moment. Okay, let's see, I don't have a picture for that. Okay, let's see. Okay. Okay, so yeah, let's talk about GERD first. So there's going to be, it's disorders of the oral mucosa, but I'll focus on GERD because that's a high value item for tests and NCLEX. So when we think about gastroesophageal reflux disease, there's contributing factors: older adults, obesity, smoking, heavy alcohol use, ingestion of large meals. We never want our patients to have large meals. If you see that as a question, a choice, answer choice, don't choose it. It's small meals throughout the day. The patient with GERD can also have obstructive sleep apnea. How does GERD manifest itself? Well, with dyspepsia, regurgitation, eructation, and so that is like really big burping or belching. So flatulence, coughing, hoarseness, wheezing, water brash. That's, oh, I threw up in my mouth a little bit, right? That is the water brash. Dysphagia. So with this, we want to educate our patients with GERD to limit their foods. And so the foods they should limit is chocolate, caffeine, fried foods, fatty foods, alcohol, carbonated beverages, spicy, acidic foods. That's really important. Now, teach the patient to elevate the head of their bed 6 to 12 inches, smoking cessation, alcohol cessation, maintenance of proper weight, don't wear tight-fitting clothing. They can take antacids, histamine blockers, PPIs, or your protein pump inhibitors, and they may have to have a let's see, they may have to have an endoscopy performed, okay? Let's go to hiatal hernia. Hiatal hernia. So this is a portion of the stomach that protrudes through the esophageal hiatus of the diaphragm into the chest. So contributing factors to this is high-fat diet, caffeinated beverages, tobacco products, medications that we think about that can contribute is calcium channel blockers, anticholinergics, and your nitrates. So this patient and also obesity can contribute to hiatal hernias. So this patient will manifest with regurgitation, persistent heartburn or dysphagia, belching, epigastric pain, dysphagia, breathlessness or feeling of suffocation after eating, chest pain that mimics angina, symptoms worsen after a meal or when they're lying supine. So this patient may end up having a barium swallow with fluoroscopy. So whenever your patient has barium swallow, we want to educate them to flush their system afterwards so they can get the barium out of their system. It will make their stool white and chalky, and we want to make sure that they flush that barium out because if they don't, it can harden in their intestines like cement. Okay, that's pretty important. Okay, so let's now talk about peptic ulcer disease. So ulcerations of the stomach or the duodenum as a result of the mucosal tissue destruction, high risk of perforation and bleeding, and this may be referred to as gastric, duodenal, esophageal ulcer depending on the location. What are the contributing factors to peptic ulcer disease? NSAIDs, corticosteroids, H. pylori infection, uncontrolled stress, smoking, caffeine, alcohol, type O blood, and they're between the ages of 40 to 60 years old. So what is the manifestations of peptic ulcer disease? Dyspepsia, dull, gnawing, burning, mid-epigastric pain or back pain. Okay, with localized tenderness. So the symptoms worsen with an empty stomach, relief noted with antacids, again, belching, bloating, vomiting of undigested food. They may have blood in their stool, and they may have decreased hematocrit and hemoglobin. So again, all of the things that we mentioned for our previous conditions is what we would do. And this patient may have to have mucosal healing agents as well as stool softeners. So that is everything for your peptic ulcer disease. Let's talk about okay, gonna go back. IBS, irritable bowel syndrome. This is a chronic disorder where the patient can have diarrhea, constipation, and contributing factors, smoking, caffeine, NSAIDs, stress, mental or behavioral illness, high-fat diet, female gender, family history, dairy products, alcohol. So with IBS, the patient may have weight loss, fatigue, malaise, erratic bowel patterns, abdominal pain relieved by defecation, abdominal distension, mucus with passage of stool, colicky abdomen with diffuse tenderness. So we want to have this patient with IBS to have a diet high in fiber, regular exercise like walking, yoga, stress reduction, eat at a regular time throughout the day, eat slowly and chew thoroughly, encourage food diary, and they may be taking antidiarrheals or antidepressants, anticholinergics, antispasmodics, complementary agents, peppermint oil, artichoke leaf extract, and caraway oil. Okay, so this is your patient that has IBS. So other conditions that I won't discuss right now to make sure you look up and reviews: Crohn's disease, ulcerative colitis, as well as hernias. We talked a little bit about hernias. Make sure you're reading up on peritonitis. That's going to be important. The different types of hepatitis. That's going to be an important topic. So remember the mode of transmission. How does the patient get the different types of hepatitis? That's going to be important. Also, when we think about pancreatic disorder, know the difference between acute pancreatitis and chronic pancreatitis. One is NPO, one is sprinkling enzymes on food. Those are all important things to know when we think about gastrointestinal. All right, let's jump into our musculoskeletal disorders. So I'll just mention some things. When we think about diagnostic tests for musculoskeletal, I want you to think arthroscopy, bone scan, the DEXA scan, EMG, and MRI. And the first condition I want you to talk about is arthritis. Arthritis is an inflammation of the joints and it results in pain, swelling, stiffness. Now, osteoarthritis is a progressive degenerative deterioration and loss of cartilage in one or more of the joints. So you'll notice with osteoarthritis, the patient can have Herbert's nodes or Bouchard's nodes. So those nodes, you've got to know those, I believe. That's important thing I believe for your exams. Okay, so Herbert's nodes and Bouchard's nodes. Okay, so with rheumatoid arthritis, this is a chronic progressive autoimmune condition. Okay, and it is a autoimmune condition of the connective tissue primarily affecting the synovial joint. So this is rheumatoid arthritis. So this patient with rheumatoid arthritis will have morning stiffness. They will have joint deformity in the late stages, warmth, redness, and edema. They can also have dry eyes and mouth, which is Sjogren's syndrome. And I think one of the Williams sisters, I think it may be Venus or Serena, one of them has Sjogren's syndrome. And Sjogren is Sjogren''. So with rheumatoid arthritis, they can have numbness, tingling, or burning in the hands and feet. And with any musculoskeletal kind of condition, think about, again, those diagnostic tests, x-rays, MRIs, all the nursing considerations that goes along with it. Now, for rheumatoid arthritis, we're looking at NSAIDs and corticosteroids being the medications of choice, as well as your DMARDs, okay? So understand that. Now, with osteoarthritis, the medications are again NSAIDs, corticosteroids, topical analgesics, and sometimes glucosamine and chondroitin. Okay. All right, so let's jump now to our next topic. We have a couple more minutes left. Gouty arthritis. So this is your gout. And so this is your patient that has high purine in their body. Okay, so contributing factors to gout: family history, excessive alcohol take, high intake of foods with purines, organ meats, yeast, sardines, spinach. So comorbidity, they usually can have diabetes mellitus or kidney disease. So there is going to be a manifestation with excruciating pain and inflammation in one or more of the small joints. Usually it's the big toe, the greater toe, and it's warm and red. It will appear warm and red. So tophi is going to be the crystals that you can see, those uric acid crystal stones, and it's very painful. Okay, so if your patient has gout, the medications of choice for chronic treatment is allopurinol. So think of it all day, every day for gout, allopurinol. If there is an acute exacerbation, maybe it's right after Thanksgiving, they had all of those organ meats, they will be prescribed colchicine. The patient with gout can also have NSAIDs and corticosteroids. So we want to teach our patients to avoid those foods high in purine, avoid alcohol to lose weight, and keep a diary of things that trigger them. Okay, let's jump into fractures. When we think about fractures, there's very different types of fractures. So closed fracture, the bone is not sticking out of the skin. Okay, comminuted fracture is fragmented, maybe because of a crush, injury. Spiral fracture makes me think of abuse, elder abuse or child abuse. Remember, we are mandatory reporters of abuse. Now, the big thing with fractures and bones and casts, we want to assess the neurovascular status. That is a huge thing when we talk about our skeletal system. So we are really concerned and we have to assess the 6 Ps: pain, pressure, paralysis, pallor, pulselessness, paresthesia. I'll say it again: pain, pressure, paralysis, pallor, pulselessness, paresthesia. And actually, there's one more: poikilothermia, and poikilothermia means cool to touch. So whenever I see a patient that has a fracture, I want to make sure I'm looking out for compartment syndrome and fat embolism. Okay, if there's a fat embolism, there's going to be early and late signs. The early sign is restlessness because of the difficulty breathing. And what is a fat embolism? It is similar to a regular emboli when we think about it, but fat cells are located inside of the bone marrow, and that fat cell can get into the bloodstream. And that's when we talk about that fat embolism. And it is most common with long bone fractures. So the first thing that we could see is restlessness, confusion, anxiety, a sudden difficulty breathing, a sudden onset of difficulty breathing. That should let you know that it's the initial signs of a fat embolism. Later on, they can have petechiae over the neck, upper arms, chest, and abdomen. Okay, so we want to look out for that fat embolism. Compartment syndrome, we want to look out for these characteristic things: pain unrelieved by positioning or by medication, cyanosis, tingling, paralysis. We want to maintain proper body alignment for this patient, okay? So with compartment syndrome, we know that the patient will have to probably have the cast cut off. And if the cast cut off does not relieve that building pressure, they may have to perform a bedside fasciotomy. Bedside fasciotomy, they will have to cut the skin and the fascia to relieve that pressure. Okay, let's jump into osteoporosis. Osteoporosis is a chronic disease in the bones caused by decreased density, and it can cause a possible fracture. Osteopenia is the precursor of osteoporosis. Contributing factors of osteoporosis: women over the age of 65 and older, men 75 and older, Asian and Caucasian ethnicity, family history, estrogen or androgen deficiency, protein deficiency, sedentary lifestyle, smoking and alcohol intake. Okay, secondary osteoporosis can be due to bone cancer, Cushing's syndrome, diabetes mellitus, medications such as corticosteroids, phenytoin, chemotherapy, immunopressants, and loop diuretics. Also, a contributing factor, maybe secondary to osteoporosis, is Paget's disease, prolonged immobilization, and then rheumatoid arthritis. So with osteoporosis, we have to look for shortened height, a history of fractures, thoracic kyphosis, and decreased bone mass. So your medications for this patient would be bisphosphonates, calcium supplements, vitamin D supplements, estrogen agonists, antagonists, calcitonins, and of course, weight-bearing exercise is going to be important. Weight-bearing exercise for this patient. Let's jump into osteomyelitis. This is an acute or chronic bone infection. Contributing factors: diabetes, hemodialysis, injection drug use, poor blood supply, or recent trauma. So this patient will manifest, the clinical cues will show bone pain, fever, general discomfort, local swelling, excessive sweating, low back pain, chills, swelling of the ankles, feet, and legs. So with osteomyelitis, there's going to be a bone biopsy, possibly a bone scan, X-ray, CBC. We're looking at the ESR, an MRI of the bone. We know that antibiotic therapy will be started as soon as possible, and this is going to be a long course of treatment. We have to irrigate the wound if there's a doctor's order, and we're also going to give analgesics because this is very, very painful. They may have to undergo surgical excision of the wound and to remove the dead and infected bone and tissues surrounding it. They may even have to have a bone graft. All right, so the patient can also have, moving to the next topic, a joint arthroplasty. So it could be the knee joint, it could be the hip joint. So when we think about knee replacement, that is the arthroplasty, so a replacement of the joint. Whenever a patient has a replacement of the joint, it could be the hip joint or the knee joint, we want to make sure that we're looking out for pain and immobility. So we want that patient to, that same day, to get up and start moving around. And of course, they're going to have physical therapy, and we have to manage their pain before and afterwards. So those are important things. We are looking out for complications like DVT, like hemorrhage, like infection. So those are important things to kind of review. The hip patient has some things where we don't want them to cross their legs. We want to have a raised toilet seat. Those are all things important. We want to keep that adductor pillow so we keep their legs extended so they don't dislocate their hip. Okay. Last thing that I'm going to mention is amputations. Amputations, I've seen some questions on amputations. Now, the big thing is they try to keep the joint. So if they have to amputate something on your patient, they try to keep the knee joint, the hip joint, or the ankle joint because that helps the prosthetic to function better. Now, sometimes they don't have a choice and they have to remove the joint. But with your amputations, this is going to be a removal of part of the body. It may be elective or it may be traumatic. A lot of times this is your trauma patients or your diabetic patients. So they can have above the knee amputation, below the knee, a midfoot or toe. What are the contributing factors to a patient getting an amputation? Well, peripheral vascular disease, severe crushing of the tissues, malignant tumors, osteomyelitis, thermal injuries. So the big thing for us as nurses is to remember we have to assess the neurovascular status, assess the patient's psychosocial status, because they're going to be going through the loss of a limb, the loss of their extremity, so they're going to be going through the stages of grief and loss, right? Dr. Elizabeth Kubler-Ross's stages. So we also want to look out for hemorrhage, infection, phantom limb pain. Phantom limb pain is real pain. So if the patient says my right foot is hurting, even though it was amputated, we still have to treat that pain. Okay, so we still have to treat that pain. It is a real pain because of the nerve endings. It's not just in their mind, it's a real, true pain that they are feeling. Now, with this residual limb, we want to make sure that we wrap it in a figure 8 elastic bandage. So that's going to be figure 8 because we want to help reduce the swelling. Okay, so we want to reduce the swelling. So this residual limb will be wrapped with figure 8 bandage. So opioids will be a medication for this pain. Calcitonin is also given to reduce phantom pain. Antispasmodic will be given for muscle spasms. Okay, and beta blockers can be given for constant dull burning pain. Okay, anti-epileptic drugs can be given for knife-like or sharp burning pain. The other part of this with your patient that has an amputation, you want to monitor their emotional, their psychosocial, their mental health status, because they're going to be going through a lot of the changes in their body image. All right. So this concludes a lot of information on cardiovascular, gastrointestinal, and musculoskeletal. I didn't talk about every single topic, but hit the highlights. If you have any questions, just keep studying, just keep reading. Use your Saunders book. That's going to be very, very good for you. Make sure you do the questions at the end of the chapter, and make sure you do your practice questions as well. And remember, think like a nurse.